And the third theme is basically talking about AI, IVF, and the future of reproduction. And I'm very excited to talk to you about this. I must confess, I'm one of those people that is a little bit hesitant about the use of AI in fertility. And I would say at the ESHRE conference this year, there was a lot of conversations about AI from the point of view of ovarian stimulation, blastocyst selection, choosing the right protocol, communication with patients, and how it can really change the future.
Welcome to my fertility podcast, Superhumans.
A space for honest conversations, expert insights, and stories of resilience.
Whether you're just getting started on your fertility journey, facing challenges, or looking to educate yourself, you are in the right place.
We are Dr. Mavis Garcia
and Dr. Wise,
fertility specialists at Markham Fertility Center located in Markham, Ontario, Canada.
Think of us as your biggest cheerleaders. Let's demystify the world of fertility together.
Welcome back to another episode of my fertility podcast. Today's episode is a little different because we are taking a trip. We're taking a trip to London, England. Well, not literally, because unfortunately, nobody has the budget to take all of you to London, although wouldn't that be amazing? But we are bringing you to London because I was just there. I attended the ESHRE conference, which stands for the European Society of Human Reproduction and Embryology, which is one of the largest and most influential fertility conferences in the world. I took notes, I paid attention, and Dr. Weiss and I together are going to walk you through the biggest and most talked about studies from that conference.
Absolutely. I did not get to attend the ESHRE conference this year, unfortunately. I was holding down the fort in Markham, but I'm very, very excited to talk about some of the studies and some of the talks that were given.
The ESHRE conference is about 3 days, and there are so many different talks and seminars and presentations all happening at the same time. So I cannot tell you about every single study or every single presentation that happened at the conference because I can only be in one place at a time. But I am going to walk you through my takeaways. As I look through my notes, I realized that all the presentations can be divided into themes. We are going to talk about some of the themes. So one of the themes is, for example, studies that look at how the right treatment for the right patient. So rather than just one size fits all, it's more personalized, which is something that we really stand for. Another theme is looking at evidence matters more than hype, because there were some studies we're going to talk about that can be very hyped in social media, but they presented really strong evidence about it. And the third theme is basically talking about AI, IVF, and the future of reproduction. And I'm very excited to talk to you about this. I must confess, I'm one of those people that is a little bit hesitant about the use of AI in fertility. And I would say at the ESHRE conference this year, there was a lot of conversations about AI from the point of view of ovarian stimulation, blastocyst selection, choosing the right protocol, communication with patients, and how it can really change the future.
All right. As we're about to get into this, please pour yourself a cup of tea because we're going to London. Of course, they're much bigger on the tea than the coffee there. Put on a lovely fancy hat, get that pinky finger up. I'm so scared all of these British people are going to email and send me DMs saying that I'm stereotyping or that I don't know about tea, which is true that I don't. But let's go to London.
All right. Study number 1. The first theme is the right treatment for the right patient. So this study came out of India, actually, and it was presented by Pahar et al. And it's a study looking at the stimulation protocol and how that determines what is the best type of trigger. This study particularly looked at whether 2 different types of trigger, either a dual trigger or a double trigger, makes a difference in fertility outcomes. And when I first looked at the study, I was like, okay, another trigger study. We've been there, done that. But this study was actually interesting because it digged into that concept a little bit more.
Before we get into the study, let's talk about some of the basic pieces here. First of all, what is a trigger or a trigger shot or the trigger injection? In an IVF cycle or an in vitro cycle, The trigger shot is that final medication that we are giving approximately 2 days prior to the retrieval. It's given toward the end of the IVF stimulation cycle once the follicles look big and ready and the hormones are looking good. And the job of that medication is to kickstart that final egg maturation step before the retrieval. Without this particular signal, the eggs may not detach from the wall of the follicles. So we may not get eggs from follicles, or the eggs that we do get may be immature. So the trigger not only is the timing, but the actual medication itself absolutely crucial to the success in an IVF cycle.
Now, this study looked at dual trigger versus double trigger. So, both dual and double triggers involve two types of medication. One is an ACG based medication, and another one is a GnRH agonist. The difference between dual trigger and double trigger is that in the dual trigger, the ACG and the GnRH agonists are given at the same time. In a double trigger, the ACG and the GnRH agonists are given at different times, usually several hours apart. And until now, we really didn't know if one trigger was better than the other, especially for patients that are poor responders.
This study focused on women classified as Poseidon groups 3 and 4. So if you're listening to this as a patient and thinking, oh my God, what on earth is a Poseidon group? Don't worry, you are not alone. This is not something that we commonly talk about with patients, like at all. So the Poseidon classification system does sound like something straight out of Greek mythology, which honestly, it sort of is. So, Poseidon is a classification system that fertility specialists will sometimes use to identify patients, especially in research settings or in research studies, who may have a lower chance of success with IVF because they may have a reduced egg reserve, reduced egg number, quality, quantity, or both. And really, the goal of this is to move beyond that layman's label of quote unquote poor responder and to better individualize treatment. If we can name something, then we're much better at studying that something.
Now, specifically for this study, like Dr. Weiss mentioned, the study focused on Poseidon groups 3 and 4. So these are women with diminished ovarian reserve, meaning that they have relatively fewer eggs remaining on the ovaries. Now, group 3 are patients under 35 years old, and group 4 are patients that are over 35 years old. So while both groups have reduced egg quantity, group 4 also face the additional challenges of having age-related decline in egg quality.
Yes, exactly. So Poseidon groups 3 and 4 are women with diminished or decreased ovarian reserve or DOR. Again, typically low AMH or anti-Müllerian hormone levels and lower antral follicle counts or lower AFCs. They're expected to produce relatively few eggs during an IVF stim, regardless of the amount of stimulation or medication that you use. The main difference is age. So again, group 3, it's for people with eggs who are under the age of 35, and group 4 refers to women who are 35 years of age and older.
This is where the study gets interesting. The researchers compare outcomes in patients using two different stimulation approaches. One is progestin prime ovarian stimulation, or PPOS, and the other one was the GnRH agonist protocols. Dr. Weiss, I think that we need to explain these protocols before we move on to explaining the results of the study.
For sure. The antagonist protocol is what the vast majority of clinics use routinely. I mean, I would venture to say 95% of IVF cycles that are going through right now are with the use of an antagonist. So basically, patients will be taking medications or gonadotropins for a couple days, and then you add in an additional medication, another injection medication, which is this antagonist medication to prevent ovulation. That is the only job of that medication, to prevent ovulation so that we can control that ovulation timing for that retrieval. Antagonist medications will include things like orgalutron or ganirelix, as well as cetrotide. PPOS stands for progestin primed ovarian stimulation. In this scenario, we do not use this antagonist injection medication. Instead, we use progesterone to prevent that ovulation from occurring. It's typically an oral medication, progesterone, that is often started cycle day 2 or maybe a couple days later into the cycle, and it is taken as a daily pill. PPOS cycles have certainly become increasingly popular over the past few years because it's certainly more convenient, right? A pill as opposed to an injection. It's cost effective because progesterone is often way cheaper than the use of an antagonist medication. And it does offer some scheduling flexibility too. But as with anything in the world of IVF, there's pros and cons. And so the cons of a PPOS cycle or using this progesterone is that the lining of the uterus will be altered and it will not be good for a transfer. So you cannot do a fresh embryo transfer in a PPOS cycle. That is the major caveat, of course, in these types of cycles. In an antagonist cycle, you can absolutely do a fresh transfer.
Now that we have explained all the bases, it was in Poseidon groups 3 and 4, which are women with decreased ovarian reserve, under 35 for group 3 and over 35 for group 4. It was comparing a dual trigger, which is HCG and agonist at the same time, versus a double trigger, which is ACG and GnRH agonist at different times. And it was looking at protocols of GnRH antagonists and PPOS. Now that we have that basis, what did the study find? The investigators looked at all patients together and they did not see a significant difference in outcomes between the dual trigger versus the double trigger. And honestly, that couldn't be the end of the story. But then they looked at a pre-specified subgroup analysis. And here's where things got a little bit more interesting. Women that were undergoing the PPOS cycles, a double trigger produced more eggs, more mature eggs, and more fertilized eggs. Specifically, approximately 26% more eggs and 32% more fertilized eggs in women that use a double trigger in PPOS cycles. And again, when they looked at the same group for the antagonist cycles, there was nothing, there was no meaningful difference.
This is really interesting. And I think that this study really caught a lot of attention, certainly caught my attention when I heard about it. Because for many years, when we've been thinking about IVF, there's this thought that, we're looking for like the best trigger strategy. And this study really suggests that we may be asking the wrong question, that there isn't necessarily one best trigger, but it really depends on the stimulation protocol. It kind of goes back to the individualization of a trigger for the protocol and ask those bigger questions.
Yeah, because this is where the thing comes in. The old mentality has always been what is the best trigger, which also said everybody gets that whatever we think is the best trigger. But now what we're realizing is that which trigger is best really depends on which protocol the patient is using, which is a bit of a different way of thinking. And it's a pattern that we're going to see again and again throughout this conference as the future of reproductive medicine is becoming a lot more personalized, which is something that we love.
Another thing that really strikes me about this study, which I mentioned earlier before we started recording, was that when you change one thing, it's a bit of like a butterfly effect in an IVF cycle. Meaning you try a PPOS cycle, for instance, because you're trying to save money or you're trying for patient convenience. There's one less injection. But then it can have multiple downstream effects that we are just sort of starting to understand. And so, for anything in the world of IVF, the different components, triggers, medications, adjunct treatments, et cetera, there are always potential pros and cons. And then there's always sort of that unknown effect or those secondary effects that we don't necessarily know about quite yet.
Now, I have to add a disclaimer. That doesn't mean that every reproductive endocrinologist needs to change their practice. And certainly, if your doctor isn't doing this, it doesn't mean they're a bad doctor by any means. This was one study. It was good because it was a randomized controlled trial, but these studies usually need more data and they need to be replicated for us to really know that this pattern holds in multiple groups doing different studies. Also, it's important to understand that the study was looking at number of eggs and number of fertilized eggs, which isn't the same thing as the final outcome we all want for our patients, which is a live birth. So it might be that if you're doing a bigger randomized control study, you might not notice any difference in live birth rate at the end of the day. And that would certainly change whether we change the practice or not based on this particular study.
So again, if this study that we just talked about was about tailoring treatments based on ovarian biology, the next study that we're going to talk about asks a similar question, but from a very different angle. So instead of ovarian reserve, we're going to talk about the immune system, which is something that we absolutely love to talk about here at Markham Fertility Center. If you're interested in learning more about the immune system and reproductive immunology, then please go back and listen to episodes of our ongoing series about the immune system and immune treatments we offer at Markham Fertility Center. That would be episodes 78, episode 83, episode 87, and 92, and of course, more episodes to come.
This study was looking at tacrolimus, T regulatory cells, and recurrent implantation failure. And it asked the question, can we identify which patients benefit for immune therapy? Now, let's be honest. The moment someone mentions reproductive immunology in a room full of reproductive endocrinologists, the room immediately gets divided into two groups: the ones that are believers in immune therapy and the ones that are absolute skeptics. And for years, reproductive immunology has been one of the most controversial areas in fertility medicine, and it still is. We go into that controversy in detail when we talked about our immune system episodes. And part of the controversy is that many of the immune treatments have been used without clearly identifying who should actually receive them. This particular study, presented by Dr. Nakawaka from Japan, took a very different approach. So instead of studying with a treatment, they studied with a biomarker. And that's what made it very interesting. Now, before we get into the study, let's talk about understanding regulatory T cells. So, Dr. Weiss, it's time to give us a primer of the immune system.
Yeah, I mean, first of all, it's very important to point out that there are many, many, many different cell types in the immune system, and it's an incredibly complex interplay of different levels going up and down at different points for pre-implantation, implantation, post-implantation, et cetera. So we're really focusing on a very, very specific piece. So this is very much an oversimplification. Let's start there. So why does a maternal immune system potentially reject an embryo? The reason is that half of an embryo's DNA comes from the sperm provider. So an embryo is always foreign to the person who is carrying the pregnancy. And why does that rejection sometimes happen? A lot of it has to do with these regulatory T cells, or Tregs, we call them for short. One way to think about it is these Treg cells are sort of like the diplomats of the immune system, if you will. You know, they're the negotiators. They're the ones that are really navigating the interplay between, let's say, that uterus and that endometrium and the embryo, and sort of doing that crosstalk negotiation to make sure that they come together and stick and stay stuck in a good pregnancy. And so, really, these Treg cells appear to play a critical role in creating what we call tolerance during pregnancy. Because, again, the maternal immune system, or the immune system of the person carrying the pregnancy, has to, quote unquote, tolerate this foreign thing, this embryo, being stuck to it.
Right. So then let's look at the study itself. So the investigators looked at 320 euploid embryo transfer cycles. Now, these weren't the average IVF patients. These were very challenging cases. These are women with recurrent implantation failures and recurrent pregnancy loss. And the average patients had undergone more than 6 prior euploid embryo transfers. That matters that there were euploid embryo transfers, because when implantation repeatedly fails, despite transferring chromosomally normal embryos, we have to start looking beyond embryo genetics.
There were multiple findings in the study, but the first finding was really interesting. What they found was that when they measured these Treg cells in these patients, the higher Treg cell levels were associated with higher ongoing pregnancy rates and lower miscarriage rates. So, in other words, the Treg cells appear to be good and beneficial, and more immune tolerance appeared to correlate with better outcomes. They then identified patients, again, who had what they felt were low levels of these Treg cells, or these Treg levels. And then those are the patients who received the medication, a medication called tacrolimus.
Now, what is tacrolimus? Tacrolimus is an immunomodulatory medication. Many physicians are familiar with it from transplant medicine, and is commonly used to reduce immune-related rejection. The idea here was, could modifying immune activity improve reproductive outcomes in women that have low Treg levels? The results were quite significant. It showed that among women with low Tregs, clinical pregnancy rates were about 69% if you use tacrolimus, and about 53% without using tacrolimus. And that is a meaningful difference. The relationship remains significant even after a statistical adjustment.
Okay, let's just take a beat here and be clear. For the record, this does not mean that we're going to be prescribing tacrolimus to everybody tomorrow. Remember, this was a retrospective study. It was not a randomized control trial, and it was not a definitive study by any means. We still need prospective trials. We still need more data. We still need more information before this can change practice. Because again, When you add things or change things, there may be other downstream effects and may potentially have negative outcomes or negative effects as well that we really have to be sure. Because as physicians, we're always saying first cause no harm.
Why I think this study really matters? Well, it's not really about tacrolimus itself, it's a bigger story here. For years, we've debated does immune therapy work? And maybe that's not the right question. Maybe the right question is which patients may benefit from immune therapy. Not every recurrent implantation failure is going to have the same problem. Not every miscarriage is going to have the same cost. So, if we can identify biological subgroups where treatment becomes more and more rational, then that would make a lot of sense. And it's another step forward towards personalized medicine.
One thing that I found really interesting about these first two studies that we've discussed is that they remind us how many factors can influence reproductive outcomes. That it's really not just about the embryo or just about the stimulation protocol, but that patients' underlying biology, the underlying, let's say, protoplasm, if you will, plays such a huge, huge role. And the more that we can potentially learn about it, both in studies and about that person themselves, that individual, then the more successful we may potentially be.
Exactly. And speaking of biology, another study at ESHRE tackled this question that patients ask all the time. A question that's becoming increasingly relevant as women delay childbearing and use donor eggs as a way to build their family. And the question is, does the uterus age? For years, we focused on ovarian aging being the only reason for reproductive aging and decreased pregnancy outcomes as women get older. But what happens if we actually remove equality from the equation? Do we get equal pregnancy rates, whether a person is 30A versus 40A versus 50A? That is the question that the next study explored.
I gotta say though, as somebody who did not attend the ESHRE conference myself, out of all of the presentations that came up, this is the one that pops up on my Google News feed about this study.
Yeah, exactly.
But I think the BBC, they had this like pithy headline, which I kind of hate and I kind of love. They just said something like, does the uterus have an expiration date? Which obviously is a terrible headline.
Yeah.
And yet it's definitely grabbed my attention for
Yeah.
sure. So this study was presented by a group out of IVI RMA group by Cristani Massaro et al. And I mean, I was in the conference, but I thought it was like really, really thought provoking and really, really cool. And one of the interesting things that came out of the conference.
The reason the study was so important is because it is something that fertility specialists have been saying for ages, which is when women get older, fertility declines because of the eggs and not because of the uterus. And generally speaking, that is true. We know that egg quality declines dramatically with age, and we know that this is a very significant factor in the decrease in reproductive outcomes that we see in older women. But donor egg cycles create a unique opportunity to study something different, which is basically, does the uterus also play a role in reproductive outcome in older women? In other words, if two women receive embryos derived from similarly young donor eggs, but one woman is 38 and the other one is, for example, 50, do they have the same chance of success?
This was a really large retrospective study, and the investigator looked at over 1,700 recipients who did over 2,700 single blastocyst embryo transfers. They were not necessarily genetically tested, but they were coming from donor egg cycles. So all of these were donor egg cycle patients. They then took these recipients or these patients and they divided them into 4 age groups. You had people who were aged 35 to 40. We can say, the uterus in essence was age 35 to 40. The second group was age 41 to 45. Group 3 was age 46 to 49. And then the final group was people who had uteruses that were aged 49 and older. It was really interesting because this makes it one of the largest data sets that we've ever seen that's actually examined uterine aging in the context of patients who are trying to conceive via donor eggs.
What did the study find? The results suggested something really important. As recipients' age increase, outcomes decline, even though the eggs came from young donors. So clinical pregnancy rates decrease, live birth rates decrease, miscarriage rates increase, and these changes became particularly apparent in women that were 49 years or older.
Now, they decreased, but it's not necessarily a reason to go out and panic. The live birth rate in people who had, let's say, a uterus that was age 35 to 40, the live birth rate was 46.2%. When we now looked at the group of women who were age 49 or older, the live birth rate was 31.7%. So this is certainly a substantial decline. But again, it's not like it dropped to zero.
Yeah, miscarriage rates also increased significantly. So it's approximately 24% in younger recipients using donor eggs versus 38% in women using donor eggs at age 49 or older.
Another really interesting observation involved the endometrium. The endometrium is the lining of the uterus. We think of it as this like warm, cushy space where an embryo will implant and grow. So, endometrial thickness was actually fairly similar across age groups, but the appearance of the endometrium changed. And in fact, with increasing age, that classic, optimal, ideal trilaminar or stripe appearance became less common. This is a really important point for clinicians. For years, we've always talked about endometrial thickness as a marker of receptivity. And there have been fabulous studies showing us that. This study raises the possibility that maybe thickness alone doesn't tell the whole story. And the tissue may look adequate in terms of the thickness, but there still may be age related changes, whether it's because of the appearance that is causing those changes in pregnancy rates, or whether age causes the change in appearance and that's just sort of a symptom of the bigger problem. We don't necessarily know.
This study attempts to answer the question, does the uterus age? And the study seems to suggest that yes, it does. And perhaps more importantly, it suggests that uterine aging becomes clinically relevant around age 49. Now, that doesn't mean that pregnancy is impossible. Absolutely far from it. Many women in this study achieve live birth even after age 49, but outcomes were clearly declined compared to women that were 49 and younger receiving donor eggs. So for me, the study changes the counseling more than the actual treatment. I would still be very comfortable offering donor eggs to women between the age of 49 and 55 years of age, which is our cutoff for using donor eggs at my Fertility Center. But if a patient asks me if I use donor eggs, does my age still matter? The answer is yes, just not in the same way. Donor eggs largely address ovarian aging, but they do not completely eliminate the effects of maternal age on pregnancy outcomes.
So it really sounds like one of the major messages that came out of ESHRE this year was that reproduction is way more complex than we sometimes make it seem, that it's not just egg, sperm, embryo, uterus. It's all of these things interacting together and how they interact through time as well.
Yeah, and when I think about the first thing that I mentioned, the right treatment for the right patient, these studies all point towards the same concept. The trigger study reminded us that different patients may need different stimulation strategies and that different protocols may require different triggers. The tricholyma study reminded us that different patients may have different immune profiles and therefore may benefit differently from immune treatment. And the donor study addressed the question that even when embryo quality is optimized, recipient biology and uterine aging may still matter.
I mean, in other words, a successful fertility treatment isn't just about finding the magic potion or the magic solution or that silver bullet. It's really about understanding the patient sitting in front of you and trying to have a good informed discussion about the pros and cons of every single thing. And hopefully we're heading in a direction of better personalized medicine.
Yeah, and the future of personalized medicine really depends on something equally important, and that is evidence. Because for personalized medicine to work, we need to know what actually works. Which brings me into the second major theme from the ESHRE conference, which is evidence matters more than hype. Listen, fertility medicine is full of new technologies, new interventions, new add-ons, new promises. And sometimes those interventions actually help patients, but sometimes they don't. And one thing that I've learned over the years as a fertility specialist is that fertility medicine has a tremendous capacity for optimism, which is wonderful. But optimism has to be balanced by evidence. Otherwise, every shiny new treatment starts looking like the answer. And this is why the next study we're going to talk about really highlights this issue.
In this next study that we're talking about, we're going to be talking about PRP or platelet rich plasma. Now, If you have spent any time in fertility Facebook groups or fertility Instagram or TikTok or basically any corner of the internet where fertility patients may gather, you've probably heard about PRP. You may have also heard about it in other contexts. Sort of seems like PRP is kind of the cool kid on the block where they're doing PRP treatments for arthritis in the knees, PRP treatments for regrowing hair. Now we're also thinking about how PRP may apply to fertility. For PRP infertility, you may have even heard it referred to as ovarian rejuvenation. I mean, honestly, that sounds pretty awesome. It sounds like a spa treatment almost in a way.
Unfortunately, the science is a little bit more complicated than that. So let's talk about what PRP is. The theory behind PRP or platelet rich plasma is actually pretty straightforward. Basically, blood is collected from the patient, the blood is processed, the platelet rich portion is concentrated, and that material is injected directly into the ovary. The platelets contains growth factors, so the idea is that these growth factors may somehow stimulate ovarian function. Now, before we go further, I want to emphasize that this study looked about ovarian PRP. PRP has been used in fertility in the uterine lining, and this study is not addressing uterine PRP at all. It's specific to ovarian PRP.
In this study looking at ovarian PRP, it was published by a group, Barad et al. And it was really cool. It was not a case report, it was not a retrospective. It was actually a randomized, quadruple blinded placebo control trial. And when we're looking at the ladder of evidence in medicine, that is like high up there. So this is some pretty fancy stuff.
So a randomized control trial, it means that patients weren't choosing whether they receive PRP, they were actually assigned to groups by chance. Randomization helps eliminate one of the biggest problems in medicine, which is selection bias. Imagine two women with diminished ovarian reserve. One decides to use PRP because she's highly motivated, financially able to continue treatment, and willing to undergo multiple cycles. The other one doesn't. Now, those two patients may be very different before PRP even enters the picture. Randomization helps balance those factors.
Another thing that was really interesting was their use of the controls. In a study like this, the control is sort of like the sham or the placebo treatment that somebody will receive to sort of compare or to control for that change that you made. What's really cool is that in the study, they did not compare PRP to no treatment at all. They actually used something called platelet poor plasma or PPP. And this is really important because everybody in the study had the exact same procedure, meaning everybody had blood drawn, everybody had to wait for their blood to get processed, everybody had an ovarian injection. And truly, the only difference because of the study design was that what the injected product contained, specifically these concentrated platelets. This is a really, really well designed study to be able to isolate just this one difference, which makes the study so much more powerful.
Another thing that I liked about this study is that it was quadruple blinded. Now, it sounds like it comes out of the spy movie, but let me explain what it means. So, in this study, being quadruple blind meant the following: it meant that patients did not know which treatment they received, physicians didn't know which treatments their patients received, the clinical staff didn't know which treatment the patients received, and the outcome assessors also didn't know which treatment the patients received. So that's what is called a quadruple blinded randomized control study. The reason this is really important is because expectations can influence behavior. So if a doctor believes the treatment works, they might unconsciously interpret results differently. If a patient believes she's receiving an exciting new therapy, they might influence perceptions as well. So blinding, in this case, quadruple blinding, reduce these type of biases.
Another strength of this study was the consistency of treatment. So again, all patients received esterase priming, the same stimulation protocol, similar gonadotropin dosing. Again, the median age of this group was approximately 41 to 43 years of age. Very, very similar group of patients. This was also a very challenging patient group to stimulate their ovaries because they did have diminished ovarian reserve. In other words, if PRP was going to demonstrate a meaningful biological effect, the study was designed to detect it.
In this study, the investigators didn't just look at AMH or hormone levels, they actually looked at the outcomes that patients actually care about. They wanted to know if there was any improvement in the possibilities of patient coming home with a baby. And what the study found is that there was no improvement in embryo quality, no improvement in pregnancy rates, no improvement in live birth rate, and no evidence that PRP was changing the outcomes that mattered the most.
Yeah, so in general, this is certainly one of the most valuable lessons that come out of a conference because just because there is a new treatment or a new thing that sounds good or sounds cool, we really have to actually make sure and see if it works or if we're applying it in the right way. And so sometimes these negative studies that show where things don't work actually provides a lot of progress and can help steer us into new directions where things may work.
Yeah, I mean, let's be honest. Patients with diminished ovarian reserve are one of the hardest patients we treat. And these are the patients that are willing to try almost anything. And honestly, who can blame them? Hope is a powerful thing. And hope helps patients move through really difficult journeys. But hope and evidence aren't the same thing. And as fertility specialists, we owe it to our patients to provide evidence, to give answers, and to treat them with compassion, which also means really telling them when something is not likely to work.
For me, I think the bottom line is that ovarian PRP remains experimental. When I have patients who ask about it, they deserve to know that, frankly, high quality evidence has not demonstrated an improvement in outcome. Now, could future studies potentially identify some specific subgroup where there may be benefits? Totally, absolutely possible. And I really look forward to seeing further research in the world of ovarian PRP. But again, right now, we just do not have that evidence. And so with ovarian PRP, is still very much experimental.
And this study shows that sometimes evidence tells us not to do more. It actually tells us to do less, which actually brings me into the next study that I want to talk about, because it is a study that addresses a scenario that I'm sure you have seen many times. I have seen many times. And pretty much every fertility specialist have had to have these difficult conversations with patients. And it is a study looking at whether converting an IVF cycle into an IUI cycle in poor responder is a viable option.
This study was presented by a group out of France by Pierre-Emmanuel Bouet and colleagues. And I actually think that this one has a lot of really cool, immediate, and really practical implications that kind of come into play right away. Because unfortunately, this is not necessarily a rare situation. For instance, let's say a patient decides to do IVF. Maybe we know that she has low egg reserve because her AMH is on the lower side. But again, AMH is just a predictor. We never know exactly how many eggs or how many follicles we're going to get. So that patient, you're excited, you're nervous, you've spent all this time and energy and effort in getting to this point. You started your medications, those daily injections, the cycle monitoring appointments. And then instead of developing that 10 to 15 follicles that we ideally want to see, maybe we get 3, right? Maybe 4, maybe 2. And so, really, we have to consider that situation, think about this difficult scenario. Do we continue with the IVF and proceed with retrieval? Or do we cancel the cycle and potentially convert it to an IUI cycle?
Exactly. And I've been there. I've had patients burst into tears during that discussion because it feels like all that effort was leading nowhere. And historically, many patients interpret a conversion to IUI as this cycle failed. Now, before we get into the study, let's explain the reasoning as to why fertility doctors sometimes suggest converting to IUI when there aren't a lot of eggs in an IVF cycle. When a patient only has 2 or 3 mature follicles, retrieving those eggs requires anesthesia, retrieval procedure, laboratory fertilization, embryo culture, and all of these things add cost and invasiveness. So the big question becomes, does IVF and going through all of that for 2 or 3 follicles provide enough additional benefit to justify those extra interventions? And that is a very reasonable question. And again, assumptions adding evidence, which is why this study is important because it specifically addressed that question.
In this study, there was a multi-center randomized controlled trial conducted in 32 reproductive fertility clinics across France. And there were over 400 cycles that were included. Importantly, these weren't hypothetical patients, right? These are women who were already like well into an IVF cycle, and they were identified during monitoring as being poor responders. So to qualify, they had anywhere from 2 to 4 mature follicles on a potential trigger day. I'm saying potential trigger day because that implies that somebody would be continuing to retrieval. These decision points really were happening in real time, exactly like it would be in clinical practice. From there, the patients were then randomized, meaning they didn't get to pick. They were randomly selected to one of two pathways. Number one, proceeding with IVF, meaning that egg retrieval, or converting to IUI. It's important to note, of course, that when we talk about IUI conversion, we're really just doing this in patients where we know that the sperm looks good, that the fallopian tubes are open, that there's nothing that's going to significantly impact their success for IUI, for instance, as well.
Before I explain the results of the trial, I need to explain that this was a non inferiority trial. What does that mean? Let's make it simple. Most studies ask, is treatment A better than treatment B? This study asks something different. It's saying, is treatment B close enough to treatment A that it remains a reasonable alternative? That is what non inferiority means. The investigators weren't trying to prove that IUI was superior to IVF. They were asking whether IVF advantage was large enough to justify the additional burden. Let's look at an analogy about non inferiority. Let's talk about pizza. Everybody loves pizza. So imagine there are two pizza places. You say pizza A is your favorite. You rate it 10 out of 10. Now there's a new pizza place that opens. The question is not, is the new pizza better? The question is it close enough that I still be happy ordering from pizza place B? So if it's a 9 out of 10, you would say, yeah, probably close enough. If it is a 3 out of 10, you would say, definitely not close enough. So the investigators in this case decided in advance how much worse they're willing to accept before they say, no, that difference is too much. The acceptable difference is what is called a non inferiority margin. So in this trial, they selected a non inferiority margin of 10%. Basically, what that means is that the investigators said before the trial study, if the IUI live birth rate is no more than 10% worse than IVF, we'll consider it a reasonable alternative. They chose that definition before they started the study. And this is critical because otherwise researchers could manipulate the interpretation afterwards.
Why 10%? This is certainly, I imagine, a big discussion point that came out because it seems kind of like a random number. I mean, is 10% a big difference, small difference? Feels like a fairly wide margin, but others might feel that it's, a pretty acceptable number. And again, there is no universally correct answer. I mean, at the end of the day, the researchers have to decide how much of a lower success rate would we tolerate theoretically in the study in exchange for that lower cost, less invasiveness, fewer procedures. And really, this answer depends on the clinical context. There's nothing magical about 10%. This is just a number that the researchers picked because at the end of the day, they had to pick a number.
Right. So now let's look at the real numbers in the study. In this study, the patients that had 2 or 3 follicles and were randomized to continue with IVF had a live birth rate of 8.9%. The patients that were randomized to convert into IUI had a live birth rate of 4.1%, a difference of 4.8%. Remember, the investigators have predetermined that if the difference was less than 10%, they would consider IUI to be non inferior. Now, 4.8% is less than 10%. Therefore, the study met the non inferiority criteria. So, there is no question that IVF performed better. The live birth rate was higher with IVF. However, the improvement was relatively modest in absolute terms. And when researchers weighted that benefit against the additional procedure, cost, and burden of IVF, they concluded that IUI remained a reasonable alternative in this specific group of patients.
As you can imagine, one of the biggest criticisms of the study is that this 10% margin may have just been too generous or too big of a number. For example, imagine a patient said a 5% increase in live birth rate is worth everything to me. And so that patient may absolutely choose to proceed with IVF. Or another patient may say, I don't want to do the anesthesia, the retrieval, and all that extra cost for just 5% improvement. And then that patient may choose IUI. Again, neither is wrong. This is really just about studying these things to learn what those numbers are so that when we go back and we counsel patients, when we're talking to patients in these situations, we can give them some concrete numbers to work with.
And that's what's important to understand. This study wasn't designed to prove that IUI was better than IVF. It wasn't even designed to prove they were equal. It simply asked whether the difference in success rate was small enough that IUI could still be considered a reasonable option. And that is exactly what investigators found. IVF produced a higher live birth rate, but the advantage was smaller than the predetermined 10% non inferiority margin. In other words, IVF might be better, but perhaps not enough better to make it the right choice for every poor responder with only a few follicles.
For sure. The biggest takeaway I think from this study is that a converted cycle is not necessarily a failed cycle. And yes, I have certainly had patients who have gotten pregnant from the IVF to IUI conversion.
Yeah, exactly. The right choice depends on cost, emotional priority, tolerance for uncertainty, reproductive goals, and individual circumstances. That's what I love about reproductive medicine. It's about having those in depth, newer conversations, and every patient's story and every patient journey is unique. So I cannot finish this episode without talking about one topic that was absolutely impossible to avoid at ESHRE 2026. And that was, of course, the use of AI or artificial intelligence in reproductive medicine. Trust me, it's everywhere. It's in medicine, in finance, education. And of course, reproductive medicine is no exception whatsoever. Now, what I really liked about ESHRE and AI is that people weren't saying, can AI do everything? They were asking a much deeper question, which is how can we use AI responsibly in reproductive medicine?
One of the really interesting things that happened at ESHRE this year was that there was a debate. This is not about a particular study, but this is about experts in the field who are standing up at the front of the room and who are having a debate with one another about AI assisted ovarian stimulation. At first glance, this sounds super technical, right? But actually, the underlying question is very simple. Every time a patient starts into an IVF cycle, the fertility physician is making a series of decisions. Which protocol should we use? How much medication should we prescribe? Which medications to prescribe? How many eggs do I think that this person is going to get? Is this person at risk of OHSS? So, do I need to balance that risk of getting more eggs versus OHSS? Is this patient someone who's likely to have a low response or a decreased response to ovarian stimulation? And so, all of these questions and then some are constantly cycling through the minds of the fertility physician as we're putting together a cycle plan for IVF.
Now, traditionally, physicians look at these questions using experience, and we look at factors like age, anti-Mullerian hormone level, androgen follicle count, BMI, prior IVF response, hormone levels, medical history, and we use our training and expertise to design a treatment plan. But the question is, can AI do that better?
Before we talk about that in particular, I think it's important to talk a little bit about AI and how AI works because AI is not magic. It's not coming up with these answers out of thin air. When people hear AI, they assume that it's like some robot somewhere out there who's spitting out these answers. That's not really how it works. AI learns patterns from data, lots and lots and lots of data. So really, it's all about data input. Like, what are you going to teach the AI that the AI can then use to create patterns? Imagine feeding an AI system information from 100,000 IVF cycles, and you're going to include things like age, AMH, androgen follicle count, BMI, protocols, medications, and then outcomes, eggs, fertilization, blasts, live birth rates, and all of that stuff. And then the AI can start identifying patterns and potentially applying those patterns. So again, a physician, the human physician, might think, okay, this particular patient reminds me of another patient I treated last year, and I did that thing, and that went really, really well. So I want to do that thing again. That is experience. That's still very, very valuable, but it is anecdotal, right? An AI system might say, this patient in this situation is X% similar to this group of the 10,000 patients that I have analyzed, and I can remember every single outcome and spits all that data out. And that's the really, really cool part. And this is where the potential of AI sounds really interesting and intriguing. It's not so because AI is smarter than a physician, that's not what we're saying, but because AI can recognize patterns in a way without emotion, that emotional charge that you may have, and it can recognize these patterns and find these patterns on a scale that the human brain just can't.
Absolutely. Now, here's the catch, and that's why debates are so important because we hear two experts give two different sides of the coin. let's talk about what the skeptical side of the debate presented, because every new technology comes with risks, and AI is absolutely no exception. One of the risks that were discussed is the concept of garbage in and garbage out. One of the most important concepts was exactly that AI is only as good as the data used to train it. If the training data is flawed, the recommendations will be flawed. So imagine if the data that is put in, it's flaw in that it doesn't have the right patient outcomes, it doesn't have the right patient age, maybe it's specific to one specific population or one specific clinic, then the recommendations that come from AI are not going to be applicable to the general patient population. And another major risk is the concept of bias. Imagine an AI system where the data is specifically trained from, let's say, younger patients, or maybe patients from France, for example. They might have genetic differences, social differences, and then therefore the AI predictive algorithm may not perform well enough for everybody else. Medicine already struggles with health disparities, and the last thing that we want is for technology, without realizing, making those disparities even worse. Another risk that was discussed is the black box problem, which basically came up all the time. And that is the idea that nobody really understands how the AI algorithms work. So AI might say, hey, increase the FSH dose, but why? The answer isn't always obvious, and in medicine, transparency matter. So even the AI experts can't really understand why it hallucinates, why it gives an answer to another, and that is something that makes physicians very worried for good reasons, and it can make patients anxious as well.
So at the end of the session, the overall consensus was actually surprisingly balanced. And I think that nobody was arguing that physicians should be replaced. And nobody was arguing that AI should be ignored. And the future probably lies somewhere in the middle with that level of potential assistance. But the physician probably at the end of the day making that final call. It's not about physician versus AI. It's really about the AI enhanced physician or physician plus AI. The physician certainly brings the judgment and brings that human touch, which is still super, super crucial in the world of fertility medicine. But the AI may bring pattern recognition and may bring that level of assistance to the physician who are making those decisions. Honestly, I welcome any technology that's going to provide better care than I can do on my own.
The AI debate was fascinating because it asked a question: can technology improve fertility treatment? But the first lecture of the meeting was the keynote lecture, asked an even bigger question, which is not how technology can affect today's IVF cycle, but how technology may affect humanity itself. And honestly, this lecture kind of blew my mind. I've been back from ESHRE for a week now, and I can't stop thinking about it. In this particular presentation, which is a keynote lecture, so it is the first lecture of the conference, they weren't talking about stimulation protocols or embryos or hormone levels. They were talking about Darwin. The keynote started with one of Darwin's most important ideas: the fact that natural selection occurs through reproduction. Throughout human history, biological barriers influence who reproduced and who didn't. Not every sperm succeeded, not every embryo implanted, not every individual had children. Those barriers influence evolution. The speaker challenges to think about IVF differently, not simply as a medical treatment, but as a technology that changes reproductive selection. Think about sperm. Natural conception sperm must complete an extraordinary journey. Millions begin, very few come close to the egg. But in IVF, especially in ICSI, we can bypass all of those barriers. And embryology selects the sperm. Actually, in the future, AI is going to select the sperm. So the sperm no longer has to complete the same journey. The question becomes, does that change the traits that are being selected in the sperm? Another topic in that lecture was the notion of delayed parenthood. The lecture talked about age. Historically, delayed childbearing carries significant reproductive consequences. But today, with IVF, egg freezing, embryo freezing, donor eggs, technology has fundamentally changed the reproductive landscape. So, where biology is still really important, has the studies that we talked about earlier, we're not 100% relying on it. Technology has become part of the reproductive landscape for humans. Now, I want to emphasize something really important. This lecture was not anti IVF, not even close to it. The speaker repeatedly acknowledged that IVF is one of the greatest medical advantages of the last century. Millions of people wouldn't exist without assisted reproduction. My own children wouldn't exist without IVF and assisted reproduction. So the lecture wasn't asking about whether IVF was good or bad, or whether we should do it or not, or whether it was playing God or not. It was simply asking, what are the long term implications of a technology that has become such an important part of human reproduction?
That is so interesting and so fascinating. I would have absolutely have loved to have heard that lecture. It really sounds like, this AI debate and this evolution feel so different, one being, of course, extremely practical and what are we going to do and how it's going to help us, one being a bit more philosophical and making us ask these questions. But at the same time, they are sort of looking at IVF in the big picture, IVF in the grand scheme of things, which I think is super, super cool. How is technology influencing reproduction?
As I was flying home from London, somewhere over the Atlantic, I found myself looking back through my notes and thinking about everything that I heard over the last few days. And what struck me wasn't a single study. What struck me was how much our field is maturing. Despite all the challenges that still exist in our field, and there are many challenges still, trust me, I came home feeling optimistic. And one thing that I hope that you take away from this episode is this, is that they are incredibly smart, passionate people around the world working every day to answer the questions that matter the most to patients. Progress may not always come in giant leaps, but it is happening, and that is something worth celebrating.
Thank you so much for joining us on this quick jaunt across the Atlantic to London as we join Dr. Garcia at ESHRE London 2026. Whether you're a patient, a healthcare professional, a researcher, or someone who just thinks reproductive science is really freaking cool, we hope you found this discussion helpful and interesting. And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast, or visit us online at myfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music, Island Memories, instrumental by Descript stock music. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.